Yeah.
We have to be a little bit more. Okay. Hi, guys. Thanks for joining. This is Essence of Medicine. Today, we're going to be talking about Neuromonitoring 101. I'm Amanda Armagast.
I'm Dr. Abbasi for Essence.
And I'm Jesse Baldwin.
Hi, guys. Thanks for joining. This is Essence of Medicine. Today, we're going to be talking about Neuromonitoring 101. I'm Amanda Armagast. Okay, let's start over.
Oh, this is live too? Okay, cool.
Hi, guys. Thanks for joining. This is Essence of Medicine. I'm Amanda Armagast, and today we're going to be talking about neuromonitoring.
I'm Dr. Abbasi for Essence.
I'm Jesse Baldwin with US Neuro.
Okay. So, neuromonitoring.
Yes,
Let's
sir.
dissect that. It has something to do with the neural nerves.
Yeah.
And monitoring, practically checking how those nerves are doing.
Absolutely.
Tell us, what do you do?
So basically, one of the ways I think of it is we're another added layer of safety for the patient during all kinds of spine and brain procedures. So we use a various amount of electrodes to keep an eye on the nervous system while the patient's asleep. One of the ways I talk to the patients about it is I'm going to come in there once you're asleep. We're going to place a couple small electrodes in the muscles that correspond to the nerves that we're working around. This is so we can keep an eye on those nerves while you're asleep and kind of tell the doctor where they're at a little bit.
Do you only do neuromonitoring for cases that involve the spine?
No, so neuromonitoring can be used in all kinds of cases. Spine is one of the bigger ones, but anytime there's any kind of neural structure at risk, monitoring can be used. So for example, we also do a lot of ENT procedures where we're concerned about any of the cranial nerves, such as 7, 8, 9, 10, 11, 12.
Well, for people who don't know, our brain communicates with our body through nerves. Practically, that's how you move your hands or you feel what you have in your hand. There is some sensor in your hand, and those sensors create a kind of signal. That signal get transferred to your brain through these nerves. The other way as well, your brain sends a signal to muscle in your hand or in your arm to contract, and then practically these nerves, like pathways of information from our brain to the rest of our body, they go, vast majority of them go through a spinal cord in the middle of our spine, but there are some nerves that go directly from the brain to the rest of your body, and those we call cranial nerves.
Correct.
We have 12 of them. Each of them has a different function, but obviously, if you do a surgery in the face or head, most of the time, those areas are nerves that go directly from the brain. For the rest of our body, for all practical purpose, they have to go through the spine. Is that correct?
That is correct. And I want to touch a little bit more about what you said about the pathways. So whenever we're neuromonitoring, we're concerned about two major pathways most of the time. The sensory pathways, which are the ones that go from our extremities up through the spinal cord to our brain, and then the motor pathways that go from our brain down the spinal cord to our muscles. So we monitor those via various different ways. The main ones are we place stimulation pads on the ulnar nerve and the posterior tibial nerve, which are on your wrists and ankles respectively. And we send that signal up to the head and we record it from the head. And vice versa, we go from the head to the muscles to monitor those motor pathways.
So I'm sorry, so the patch, it sits on the skin, correct?
Right, we actually place the patch. Sometimes we use needle electrodes depending on the patient. We place it right on those nerves and we stimulate those nerves at various.
You have some examples of that?
Yeah, I mean, I can always break some out, but
No, well, we don't have to break it out, but if practically, there are two kind of electrodes, right? Some that, like a sticky thing, but when you get an EKG, like something that sticks your skin, and certainly that signal then have to go through the skin. And then there is another one that is a small little tiny needle.
Correct. We sometimes use needles. We sometimes use the sticky pads, depending on the procedure we're doing typically. And if the different pre-existing conditions the patient may have, we might use needles because they're a little bit more effective at stimulating because they can reach further down.
And they are more effective because they don't have to go through the skin to get to the signal. Now, one thing that very rightfully you said, these are different pathways. The path that goes send the signal from the brain to your muscle, we call it motor pathway, and the path that you gather sensory information like feeling and so on. Those are the beginning of the input or beginning of the signal is in anywhere in your skin, but they go in a specialized pathways through your nerve, through the spinal cord to to your brain. So for the motor, signal start in the head, goes to your muscle. So practically you have signals in the head and in the muscle. Is that correct?
That is correct. One of the ways I like to think of it is we're conducting a train and we're starting this train at point A and we're going to make sure it gets all the way to point D. Point A being the head in this example and point D being the foot. So we're going to start that train at point A and we're going to measure it. It stops point B, point C, and point D to make sure it gets all the way there. And if it's not getting there, we can see, okay, it didn't make it to C, but it made it to B. So maybe something's going wrong in between B and C, and we can more accurately tell our surgeon, hey, this is where there might be an issue going on.
Let me ask you a practical thing. Carpal tunnel is a very common kind of procedure. Most of people know what it is and so on. But prior to getting even carpal tunnel, you have to do a study, right? You put some electrodes in certain areas and you measure the electrical activity, the performance of the nerve in multiple places, and then you can tell if that problem is in the neck or in the wrist.
Correct. That's exactly what we do during spine surgery.
Yeah. Well, why don't you describe with the carpal tunnel, but the way you can tell that it's the nerve pressure is in the wrist and not in the spine. How do you do that?
So you would measure where that disconnect is coming from. So in that situation, you're going to be stimulating the median nerve or whichever nerve is going to be compromised.
Which is about here?
Right. It's right down the middle. Median is just for middle. And whichever nerve is being compressed by the bone or whatever structures pressing on that nerve, you can test from distally from that, which would be further away from the nerve, and see where that signal either slows down, stops altogether, or becomes a lot weaker. And you can diagnose where the problem is and what to do about it. Because if you're getting the signal from, let's say, your elbow down to the hand perfectly fine, the issue is not there. But then if you're starting the signal up here and it doesn't get to the elbow, we can deduce that this issue could be brachial plexus.
Sure. Now, let's say you want to do what we call upper extremity, meaning arm, EMG, and CV, to find out if I have carpal tunnel. Where would you put your electrodes on my body?
So for carpal tunnel, we do some carpal tunnels, but we do primarily do spine. But we would want to follow either the ulnar nerve up, which goes up along the inside.
Electrode in the wrist, electrode in the elbow.
And we would also want some in the hand to make sure that we're testing that muscle that nerve is talking to, basically.
Yeah, which is practically muscle that could innervate the thumb. Is that right?
Yes, those abducens and adductor muscles.
Yes. They are fancy at the names, abductor, abducens. And now, and then you have an idea how fast that signal should transfer in the nerve.
Correct. We do this.
The details.
We do that with spine as well. We have so our sensory waveforms, which we can show in one of our slides, they're marked by their latency, and the latency is how long it takes for a signal to get from point A to point D, wherever you're measuring
how fast nerves are.
Very fast. So microseconds, milliseconds.
Yeah.
We measure from the arms. We have these potentials, and we mark them by N20 and N23. And so that N20 is marking how many milliseconds it takes for that signal to get from your hand to your brain. Same for your feet, but those signals are a little bit slower. We mark those at 37 milliseconds.
Now, even though they are very fast, I want to emphasize it is not the electric wire fast. Meaning that, in electric wire, the electricity or the signal in your computer travels almost at the speed of light, meaning about 160,000 miles per second or 320,000 kilometers per second. Even though our signal in our nerves and so on are fast, but their travel for certain things, nature is amazing. For those nerves that it's important for you to be fast, for motor neuron, it is about 200 meters a second, actually a little below the speed of sound. But for those nerves that are not that important, like how you feel things and so on, there are actually some of them are just few meter or few yard per second. Meter, yard, let's change it, use it exchangeably for this conversation. But so when you are talking from your brain to your foot, it is, let's say it's about two yards. The motor, meaning how fast you can tell it, that signal goes around 200 yards per second. but for your toes tell you that you are stepping on something and so on, almost can take a full second for the signal get to your brain. So it's not instantaneously.
Right. And I think that's super interesting that you mentioned that it's like a trait that nature has created to withdraw yourself from that painful stimulus. Like if you step on something, I think it's so interesting that you actually find a lot of muscle memory in the spinal cord.
Yeah.
That way it can eliminate some of that time it takes to go from the foot all the way to the brain.
And that is actually amazing. And let me tell you an anecdote about that. I accidentally caught a turtle.
Accidentally? How do you accidentally?
So sad.
So I throw it's something in water. Next day I come, I forgot to take my my fishing pole, and it was a turtle, and it has a huge hook
Mhm.
in the throat. So it was I practically did a mercy killing on the turtle. Don't ask how. And
That
I
was
cut
my
the
next
head off. That I cut the head off. The next day, turtles are reptiles, and because of their reptiles, they don't energy requirement is not as high as mammals. The next day, every time you would touch the foot of the turtle without the head, the foot would still retract.
It's that memory that's in the rest of the
Spinal
nervous
cord.
system.
Yeah, spinal cord. So because of that, that your nerves, the body knows that it's not as fast enough for certain input. It has created certain pathways that it doesn't have to go all the way to your brain and come back. So it can act intermediarily in your spinal cord.
And the speed of those pathways is super important. That's also something we monitor because
Yeah.
while we're worried about the signal decreasing and it being weaker or not going there at all, we also are concerned about the latency of which we said was how long it takes. Because if that time it takes to get that signal to your brain slows down significantly, it can have, major implications. Like in the legs, you're gonna have a lot more trouble walking if you're not getting all that input from your body, like your proprioception, where you're at in space, where your foot is. Getting those signals up to your head as quick as possible is super important.
For all practical purpose, there are this major three category of neuromonitoring, right? You measure how our sensory, how the nerves that telling our brain what's going on in our body. But we call that SSEP. What's that
Correct.
stand for?
Somatosensory evoked potentials.
Meaning that you give a signal in the hand and you measure in the electrode in your head, in your scalp, how fast that goes there.
Correct. So we place some small electrodes in the scalp, and for the somatosensory, we place them over the somatosensory cortex.
Where is it?
Right behind the motor cortex.
Well, if for people who know our body, our brain is organized, that most of the time, things that have something to do with the motor or in certain location bunched, like, they're together, and things that had something with the feeling, they're in other area. So area 4 is the motor, and some other areas before that is so-called practically in the front of the skull or brain is where the most of the motor stuff are, and and then there is a huge gap in our brain. We call that central sulcus, or the Sylvian sulcus is on the bottom, and then motor sulcus is here, and anything behind that is mostly sensory. Is that correct?
That's correct. Behind the central sulcus is going to be that somatosensory strip.
Somatosensory.
And in front of that's the motor.
So how many electrodes do you put there?
So around the head, we place 4 when we're doing sensory, and when we add motors, we can place anywhere from 2 to 4 more. And those
Can
motors.
you show it on my head?
Absolutely, I'd love to. I'll
Yeah.
come behind you and show you.
You're good.
Okay, so we're looking at the sensory strip here, which is going to run from how we do it.
Let me turn it a little so people
We
can
run
see.
right behind the ear here, and we come up here to right down the midline, which is where we can get most of the signals from the feet. And then we come a little bit further out to where we get a little bit more signals from the hands.
Okay, and then what do you do with the hairs?
I was just gonna ask, do you have to shave?
We hope they don't have too much.
Uh-huh.
A nice bald patient is always great.
Perfect.
But-
Ideal.
But I mean, you go through hair, you can part it however you need to, but
Do you use a material, a gel-like material that they make the conductivity better?
intraoperatively, we don't because we're using those needle electrodes and they don't really have a lot of resistance. But in a clinical setting for EEG or running sensories, they would use a conductive gel and those sticker pads that we use.
So this is somatosensory evoked potential, and then there is so-called when we want to see how the path that brain tells our muscle what to do, What do we call them?
Those are motor evoked potentials, transcranial motor evoked
Why
potentials.
do we call them evoked potential? What do we call it that
Because
way?
we are stimulating, we are evoking a response from the
Mhm.
nervous system, and then we are recording it later. So we are evoking that synaptic potential, and the synaptic potential is basically the way the neurons communicate with each other.
Yeah.
We are evoking that potential.
No, but those cells, those action potential, those activity of the nerve, they're so minuscule.
Yes.
I mean, compared to like people, are used to electronic and so on. You like probably your phone works with 12 or 5 volt or something like that. Those are minuscule compared to electronic we know. How can you figure out in the all activity of the brain and our body that this is the signal, that you start a signal here, you want to see where it goes, or you start a signal, literally you evoke the potential, meaning that you give electricity in the hand, and then you see when you receive that electricity in the brain. But those potentials are so low. How do you crystallize them out?
So each individual synapse, which is where the two neurons communicate, is going to be microscopic. But there are millions upon billions of synapses in the brain. And the areas that we choose to monitor from along the brain are heavily populated with those neurons and those synapses. And those synapses, our brains are like computers, like you've mentioned before. They run off of electricity. So whenever they synapse, it does create a potential going across the neurons that is electrical, and these are microvolts. But we are able to record those microvolts, and from that we are able to get our potentials. And it's the summation of millions.
Summation and repetition. Yeah. Now, see, practically, this is my understanding. You correct me, but individual signals, even though we can measure, they drawn in the Z of all the activity of the brain. But all the activity of the brain, for all practical purpose, are random, meaning that you put the electrode on, you stimulate. At first, you don't see anything, but
Correct.
then what you do, you overlay all the signals you get. So what happens is all the other activity, they are random. They random it out itself. They practically in one area, one signal is up, the next second is down, and so on. They practically annihilate each other. But the signal that you send from the hand always arrives at the same time.
Yes, it is typically going to be stronger because we're
Yeah.
actually stimulating it.
How many times do you have that repetition? 200 times, 300 times, 400 times
It can
before you
depend.
see a signal?
Yeah, it can absolutely depend. Sometimes if there's not a lot of like electrical interference in the room or the patient's super healthy, we can see that response within like 10 to 15 responses. Sometimes if there's a lot of outside interference, we can average up to 500 times.
What would be like an example of outside interference?
So we use a lot of electrical equipment. Our cables run along the floor and up to the bed. So sometimes any kind of power cord, if it's not perfectly grounded or a little older, it can emit some stray electricity. And since we're working with microvolts of electricity, any kind of outside interference is going to leak into our electrodes because they're just recording electricity. They're not specific on what they're looking for. We have to tell it what to look for.
So and then so we talked about the sensor evoked potential, SSEP. We talked about the motor evoked potential, MEP, and then there is what we call free run EMG. What that stand for? What is that?
So free run EMG is probably one of the ones that surgeons really rely upon the most. And it's a free run EMG is electromyography, which is recording muscle activity. And whenever we're working so close to the nerve roots control that muscle activity. So any kind of irritation or any kind of damage potentially to those nerve roots is going to elicit some responses, and we're going to see movement in the muscles, or whether the muscle movement is minute or whether it's a big movement, you see the patient kicking their leg. Either way,
Sometimes they jump on the table.
they do.
Really?
And then you hear me in the corner say, "Oh, my bad." And
Except if they're paralyzed.
Mhm.
So meaning when they're paralyzed, the anesthesiologist put a medication in that practically disconnect all those nerves from causing the muscle to contract.
Right, it eliminates the muscle's ability to communicate with the nerve.
Okay.
Those synapses we talked about, they become unable to receive the message that they're getting from the nerve.
Yep.
And so we also are able to record that to make sure that all that paralytic is worn off before we can proceed with the surgery to make sure it's safe.
Now, there are some other rare occasion that you do neuronal monitoring. We don't want to go in depth of it, but practically, sometimes you do acoustic evoke potential or
That's correct.
other, but practically anytime brain get the input from any of our sensors, and we have many of them, like our ears and so on, you can evoke that and then measure how those pathways are going. Very shortly, can you tell us what other quality of beside SSEP, MEP, and free run EMG,
Mhm.
what other quality are you able to monitor?
So, like you mentioned, we can monitor the auditory pathway. These
But
are
What
we
how do
put
you do
these
that?
little earphones in them while
Yeah.
they're asleep, and they make these clicking sounds back
Yeah.
and forth. And we
That-
can follow that click. That's point A in the train station,
Uh-huh.
and we follow that click to the ear, to the auditory nerve, and then to the brainstem, up the brainstem, and out to the auditory projections in the temporal.
Isn't that amazing?
What is that for?
That is for any kind of brainstem tumor. There's a spot in the back of the brain for the skull-based procedure called the cerebellopontine angle that a lot of these nerves are very close to. And so anytime a surgeon is working in that area, they want to monitor this pathway.
And from the knowledge actually they gained, now we have actually a small little electrode that we can implant inside of the
Mhm.
ear, cochlear implant, or in that area of the brain we call pontine cerebellar pontine corner, that we can put the electrode there. The microphone breaks down the sound information, create electrical impulses that send either to our inner ear or to our brain directly, so deaf people can hear now.
My grandpa just got one of those. And
Wow.
yeah, I was
Now
wondering
you
how
know how
they
Yeah.
it works.
They're fascinating. I mean, how do you turn electrical stimulation, how do you turn electricity into a sound that you can comprehend and put meaning to?
I know.
Yeah.
It's crazy.
And that is because we know exactly where those, like in our inner ear, we know where the nerves are for lower frequencies versus higher frequencies. Then we call that topography. Our brain has a topography, meaning like the same thing that with the sensory, that our hands go to certain area, our arm go to another area, our legs go to another area. In the brain, we call it even homunculus, meaning a
Yes.
small little human. Because when you sort it out, you see there's almost a reflection of a human body in our brain. Obviously, the tongue is big, the lips are big, fingers are big, yeah.
Oh wow.
So because we know exactly where to expect the signal from the hand. Same thing with those with the sounds. We know where the higher versus low frequency are. So that electrode is made that the microphone breaks those frequencies, and then it sends it to that area of higher frequency where they belong to, lower frequency where they belong to. And it's amazing. Brain rewire itself and make sense of it. It's amazing.
The brain is really cool.
Yes.
Yeah. So what other quality are you able to measure beside these four that we just talked
Yeah.
about?
Can you measure visual?
We can. It's very unreliable
Okay.
though. I've gotten the opportunity to do it 2 or 3 times and have yet to get a good response. There's a lot of variabilities and reasons why we can potentially lose that signal. So what we do is we put some goggles on the patient and we flash some red lights. This is all while they're asleep, and we can measure that signal there. Point A is the eyes. Point D is going to be the occipital lobe, which is the back of the head where your vision is processed. We try to follow that signal all the way back, but we have to have perfect anesthetic. And unfortunately, in a lot of these cases where they're worried about vision, the patient's already lost a lot of vision. So if we don't have a visual pathway to follow, it's like driving down a back road when there's not a road. You're gonna have a bad time. It's not gonna work.
You're just kind of winging it.
Yeah.
like,
So we can monitor them in the perfect setting. We can get a good signal, but it's very difficult.
Now you have done a great job to prepare a presentation.
We basically covered it.
Well, but I want to beg for people who are more professional regarding that. I want to have you just talk a little, go over that and talk what you have prepared. We should use it since you have done the great job to preparing that.
Well, thank you.
Yeah. I would say, just here, I'm going to pass it to you, and you just go over that. Tell what on a little more professional way, what we just talked about, what those qualities are, what does a little more detail, please go ahead.
Right. I mean, we covered a lot of these points, but so I just kind of started off with like, what is neuromonitoring? We've talked a little bit more about what it means to the patient and how we can explain it to a patient. And so in a more professional setting, neuromonitoring is used to measure the integrity of these neural pathways and all kinds of nervous structures during any kinds of procedure. We can do all kinds of different procedures. We saw a retroperineal recently, where we were concerned about exposing and working our way through the lumbar plexus. So anytime there's any kind of nervous structure at risk, there's almost guaranteed a way we can neuromonitor it.
No, I think one thing we didn't talk about, I'm hoping you are going to show us, is that is not separate, and it has something to do with free run EMG, is that sometimes we actually have an electrode that we put that electrode on certain areas and see if practically that area is too close or far enough from a nerve. Or as well, sometimes on purpose, we stimulate a nerve to see what the function of that nerve be. And that would be stimulation.
That would be triggered EMG, yes.
Triggered
It's
EMG.
basically an evoked potential for EMG, where we're stimulating the nerve or a pedicle screw or a Jamshidi, whatever we want to stimulate, we're testing to see if we're seeing a response from the muscles.
Okay.
And that tells us a lot of things. Sometimes we want to see a response because we want to make sure we're in the right spot. Sometimes we don't want to see a response because we want to make sure we're further away.
You remember one time I think I was tricking you. I was holding my electrode in the air and looking funny to all people and think, it's like, what's your stimulation? And then that's sort of a surgeon's funny way to make sure
They're paying attention.
they are paying attention
Yeah.
and so on. So what happens if I just, like, instead of putting a electrode in the body, I just let it float in the air and I ask you, what's your threshold?
So it is a tricky thing to do to us because it looks similar, and all of my team knows that you're going to do that to them too. So if they're not on it, let me know. So it looks the same. We're going to see like a line, basically just a flat line that's moving. And then you can stimulate higher and apply more electricity or stimulate lower, but you'll never see a response. And our equipment will show us that there is not a good connection.
Continuity,
Yes.
impedance.
Impedance, yes, sir.
Do you want to describe what that is and how do I trick you and how you are not going to be tricked by my trick?
Right. So the impedance basically measures that there's not that there is good connection between the probe, which is what we're using to stimulate, or the electrode and whatever it's coming into contact with. It measures the resistance between the probe and the pedicle screw or the probe and the skin or whatever. And whenever we don't have a good connection, we have this cute little Z that pops up on our screen. It's very small and in the corner with our triggered EMG settings. But yeah, you keep an eye on that. It'll also show you, let's say we're applying 20 milliamps of stimulus. It'll show us that only 3 milliamps are getting to the muscle or wherever we are. So that's another good indicator of, okay, this isn't making good contact.
Yeah.
And sometimes you aren't trying to trick us and there's maybe some kind of liquid or something in the way between the probe and we can get some suction to clean it up.
It's always their fault. They disconnected
They do.
One of your plugs or something.
Even in podcasts, we get to blame anesthesia.
Yeah, even in podcast. Hey, Brian, it's all you.
I wanted to blame Brian on this too, but I didn't want to insult any other.
We can blame Brian.
Brian.
No, he's such a good anesthesiologist. He can take it and survive. Now, practically, the impedance is like you want to see if there is a connectivity in a circuit. Obviously, our body is not as good of a conductive material, but still some electricity passes through, and that is what impedance is. If there is some electricity passing through, or absolutely no electricity passing through, like Brian disconnected your thing, or my probe is disconnected, is broken, or
Naughty surgeon.
naughty surgeon trying to
trick us.
Yeah,
trick-
pull pranks.
Yeah.
pull pranks, exactly. So please go ahead. I
absolutely.
really want to see more.
So we already kind of covered a lot of this. We talked about EMGs, we talked about sensory, we talked about motor, we talked about the auditory responses. Basically, during spine, we're going to combine multiple of these modalities is what they're called.
Let's talk about spine. So
Yeah.
what is the obviously the vast volume of neuromonitoring is done on the spine procedures.
Correct.
And compared to all other procedures, spine is probably, I would say, 80 to 90% of the workload you guys do.
Yes, that's about correct.
Why is that? Why is that so important?
There's more nervous structures at risk during a spine surgery than there is for, say, a shoulder.
Do you mind to bring that model here? And I want to show you the importance of that. And so practically brain is up here, and between each two vertebrae, there are tons of nerves that are coming out. Each of them do something important. And in a spine surgery, we are very, very close to them, like sometimes millimeter. And if we cause them any harm by pushing on them, like sometimes we use electricity to stop the bleeding. These are things that you have a good understanding depending on where we work. How is the function of this nerve during the entire time of the surgery?
Right. That's what we're keeping an eye on. We're looking for changes, basically.
Should I tell you, it's a very sad thing though. Not
Okay.
every surgeon uses neuromonitoring.
I agree. That's very sad. However, you can help us and everybody monitor more. I'm all here for it.
Yeah. So and the idea is like, in a way, they're relying on their experience, and that might be good, and they're relying on the anatomy and so on. But if you have a tool to tell you what the function of the nerves are in real time, and not using that, I think that's a sad thing not to utilize such a powerful tool you have.
Is
Mhm.
that
This
a
procedure.
question that a patient would be able to ask? Like, will my
They should ask.
Mhm.
They should ask their surgeon, do you use neuromonitoring or not? And my answer to that is always, except some very rare situation where we traditionally don't use neuromonitoring. It
Like
should
what?
be like if patient is awake patient can't tell you if you're close
Yeah.
to the nerve or not.
We're kind of like their voice when they're asleep.
Yeah.
So what if they're under MAC?
So, I mean, I would monitor that personally because they're not going to be cohesive enough to really understand
Yeah.
what's going on or like to even answer questions that are asked of them.
And
So I
that
would
is why
recommend it.
in our protocol we are using as well for most of MAC, or if the procedure that the chance of damaging the nerve is extremely low, that still I would say is reasonable. But for most major procedure, I think it should be standard of care to use neuromonitoring. Unfortunately, some of my colleagues would disagree with me.
We'll take it to the board and the insurances.
Yeah, yeah.
There are some instances where monitoring is done for awake patients. These are primarily in like procedures that aren't going to be as invasive, such as some pain management. There are some monitoring that's done while awake. Just place those sticker pads on patients so we're not placing any needles. And then it gives more verifiable, viewable data that there may be some nerve root irritation, that maybe the patient has some like neuropathy or something, and maybe they can't pick up on it.
Yeah.
Okay.
But we can have the actual data supporting, okay, maybe we're a little too close to a nerve that we're worried about.
So please continue.
Yeah. So we were saying during spine, we're primarily going to be running the EMG, the somatosensory, and the motor potentials because it's the best way to keep track of the entire spine. For the motor potentials, we're worried about the ventral side of the spine, which would be the front side. And for the sensory, we're worried about the back side. So whenever you see like an anterior procedure, we're going to be more insistent upon wanting to run motors because you're placing a cage that could potentially push upon the cord.
Yeah. So practically in all cases, you're using free run EMG specifically because when we put a screw in, I put the electrode on the screw and you can tell me how close I am to the nerve or not.
Correct.
The screw goes in that structure we call pedicle. And as you see, there's a nerve above and nerve below it. You're mostly concerned about the nerve below because nerves are running right here. But as well, if the screw breaches in, meaning going inside of the canal, it can push on this nerve that's coming out here. Now, that amount of electricity we put there is really as well minuscule.
That's correct. It's
Talk about
up to about 20 milliamps is what we typically apply whenever we're testing. We call it
But I do
medical
more,
testing.
right?
You do more. You go up to 30 just to be extra safe. So I believe the metric is for every milliamp of electricity we're applying, you are ideally 1 millimeter away from a nervous structure. So we're testing, depending on where we're going, sometimes when we're going through the foramen, which is right where those nerves exit, we're going to be testing a lot lower because if we were to test at 5, 6, there might not even be that much space period, but we want to make sure we're 3 to 4 millimeters away.
Yeah. Now let's start with that. If you are doing what we call the stimulation of the nerve, first of all, patient cannot be paralyzed.
Correct.
Because otherwise you literally have one electrode in surgeon's hand, the other electrode is somewhere in your legs that measures in the lumbar spine what the activity of that nerve is that is connected to that nerve that we are next to anatomically. Now, obviously, you have to know which nerve I'm working on, because you're going to pay attention to specifically to those muscles that are supported by that nerve. But by you putting practically electrodes everywhere, so you have describe your screen. You know, if you have a picture or something.
I did not include a picture of what my screen looks like, but we basically, for the lumbar spine, we're going to monitor some muscles in the quads for every case, and then two different sets of muscles in the calf. We would monitor the anterior tib, which is super important for foot drops. So lifting your foot primarily is used by the anterior tib. And then we also monitor the medial gastroc muscles, because those core group of muscles there do a good job of demonstrating the innervation from nerve roots from L2 to S1.
So you put those electrodes always in pairs.
Yes.
Tell me what's going on.
Pretty much all of our electrodes just talk to each other. So like when we're doing our sensory, so the signals that we are doing from up here, they talk to each other and we measure the electricity between them. For EMG, it just gives us a better spread and coverage total of the muscles, because those electrodes are all talking to each other and telling each other what they're seeing.
Yeah.
And our amplifiers and all the technical stuff, it subtracts and adds and gives us a signal.
So, and the idea is redundancy, number one, but as well, when you send a signal, two electrodes that are closer to each other, they should receive that signal faster or around the same time, rather than the electrode that is another foot away.
Correct.
And that can help you to identify which signal going where, at what speed and so on. And that's really good calculation for you to, and now the stimulation, we call it stimulation. How much energy do you put in a stimulation? We talked about that every milliamp tells you you're a millimeter away, and we go up to 30. But if you touch a nerve directly, how many milliamp? Milliamp is how much of the energy you put that. Do you usually get the
I would
signal?
start at like 0.2, 0.3, depending on what nerve we're talking about. Like if I'm working on like the facial nerve, we're going to start at 0.2 and work our way up from there, because that nerve is super close to the muscle that we're recording from, which would be around your face. For the lumbar spine, the muscles are a little further away, so that signal's got to go further. I would still, if we're directly on the nerve, I wouldn't start higher than 0.5.
So in some surgeries, as a neurosurgeon, there is something we call tethered cord, meaning a part of the nerves when you are growing up are bunched together, and there is a small little ligament still holding it back. And this is a genetic abnormality some people have. The solution for that is opening up your spinal cord, which I have done, finding that tethered cord or the ligament that connect that and cutting it. But how do you know it's not a nerve? How do you know it's safe to cut it?
That's where we come in.
That's where they come.
You can stimulate the non-nervous tissue and you won't see a response unless you're stimulating it entirely too high. And then whenever you stimulate the nervous tissue, you will see a response.
And that is where you use 0.5, 0.2.
Correct.
Directly on the thing. But for OLIF procedure, for minimal invasive transcameral OLIF, we are trying to avoid the nerve. We are trying to make sure that we are far away from the nerve. By, here, if this is again our place, we want to be, when the nerve is up here, we want to be at least few millimeters away from that. So what do we usually stimulate for the transcameral OLIF?
Depending on where we're at, if we're going through the foramen, we start at 3 and see if there's any responses. And then once we feel safe at 3, we'll go up to 4. And so since that area is so small, 3 to 4 milliamps is going to be sufficient to let us know that we're in a safe spot. Whenever we're placing in the pedicle, we can go up to 25 because we have to conduct that electricity through bone, but B, we can know that we're further away.
Actually, I want to show that because I think
when you do that, they can't see it.
Okay, let them share that, because I think this is important for people to understand what the differences here are. And yeah, here. So if this is your spine, I don't have a pen or anything, but practically, this screw goes through a bone structure. Right here, the screw goes through a bone structure, and there are nerves above and below. So electricity would need to go through the bone to get to the nerve.
Correct. And the bone has a high resistance.
And for that reason, in a regular open surgery, not my surgery, what is the typical stimulation? What is normal? What is safe? What is not safe? What would you say?
So the threshold for potentially replacing a screw or for us to mark it as what we call an alert, it's going to be about 8 milliamps for pedicle screws. Of course, that's going to be up to the surgeon's discretion. Sometimes the pedicle is pretty worn down or there's not really a better place to put it. They're going to leave it there. But 8 is where we mark it as an alert. 10 is kind of where, you know, we would revisit it, make sure we through X-ray, through navigation, we're going to make sure it's in a good spot. Of course, at the surgeon's discretion, and then we stimulate up to 20 before we call it good.
So, practically on the surgeon's side is, as we just discussed, if you have direct connection, meaning the screw is branching or breaching out and touching the nerve, you would have signal 2, 3, 4.
Absolutely. And if you start too high, if you start stimulating at like 10 or 15 and you're medial breached, you're going to kick the Mayo stand off the.
Yes.
The patient's going to start kicking and moving.
That is why we start low and go slowly up. We start low and go slowly up. And once we get to 10, then we can go 10, 12, 15, 20. And then we can, on the higher level, we can go up faster.
Why do you go up? Because I remember Jesse said that most people go up to 20. Why do you go up to 30?
But no, let's start. Actually, that's the important thing. So imagine when you have a screw here, the head in a regular surgery, everything is open. The screw has connection to the bone and surrounding tissue that inside of the bone. And if it's connected to the nerve, if there is a bad positioning, the screw may touch the nerve, but the head of the screw is open and we put electrodes right on that. In this situation, we have a good understanding. If you don't have any signal at 6 milliamp, then it is less than 50% likely that you have connection to a nerve. If you are at 8 milliamp, your threshold, it is less than 10% likely that you have connection to the nerve. But if you get to 12 and so on, it's practically negligible that you have any connection to a neural structure in the nerve. So, but we now understand all of that for open surgery when you have no connection. Now, I don't do those surgeries. I can do that. I have done thousands of them. But what I do is this is skin, and I put something that's long and has connection to a lot of surrounding tissue. Some of the tissue energy get dissipated along the way. As a matter of fact, we are going to publish that study to establish what is a safe threshold for our surgery. For our surgery, first, before we put the screw in, we put a long needle. We call that Jamshidi. We stimulate that Jamshidi up to 30, meaning that even if a lot of energy get dissipated, there's enough energy still on the bottom of that needle, long needle, that if you have connection at 30 milliamp, you know it. But then when we put this, literally we put the bigger screw in, the screw actually is much bigger in diameter. So meaning that the energy level of that is still can get dissipated, but most of the connection is inside of the bone where we are actually interested. We usually, our experience shows that if you don't have anything actually that is part of our study that we are going to publish. We have shown that anything below the 6 in the open surgery correspond to almost 11, 12 to our procedure. And 8 in the open surgery correspond to the 14.
So what you're saying is like during like an open posterior fusion, a stimulation at 8 to 10 would look like stimulation at like 6 to 8 for the OLIF.
Yeah. So in the open surgery, you say your the alarm goes up at 8. For open surgery, 8 is your alarm. For OLIF procedure, somewhere around 13 should be your alarm because some of the energy get dissipated. So 6 in open correspond to 11, 12. We are still, our study is still running.
Right.
6 in open surgery correspond to about 11 in the MIS with the tower screws, obviously depending on how big the patient is and so on and so forth. But the good news here is if patient is bigger, most of that is fat.
Yes.
And fat is insulator. So meaning that we are able to still validate that thing. So 8 in an open, so 6 in a regular surgery is about 11 in the MIS. 8 in a regular surgery is about 13 to 14 in a MIS or minimal invasive surgery. And 12 in the open surgery is corresponding somewhere between 15 and 16 in open
Okay.
surgery. That when I started that, I didn't have any of those data. So my threshold was 20. But then I saw 17 is safe. And until now, our threshold is 17 to rely that that's a good screw placement. Below that, like if I'm below between 17 and 14, that's where the surgeon judgment come from.
Mm-hmm.
It is the same like between 8 and 6 in a regular surgery. That's where the judgment come from. I'm very comfortable with that and so on. And sometimes bone is weak. Sometimes the bone is broken. Sometimes there is a conductivity through a vein or artery or something else. And that's where the judgment come in. But that study is actually very interesting. It's running right
Yeah,
now.
I'm excited to see it.
Yeah. It's actually, I'm hoping for us to publish it very soon. But I'm going to go back here because we should continue this. It's very interesting. Please. Okay, Jesse, go.
Well, we'll kind of run through real quick, and I have 2 quick questions for
Yes,
you too once
yes.
we get there. So this is a little bit more about what our EMG actually looks like on the screen.
Mhm.
So we can see here, this is what our quiet EMG looks like whenever we're starting to test.
Mhm.
And then if you're irritating that nerve or maybe something's going on around it, it's going to look a little bit like this. And these are just different types of EMG activity, neurotonic discharges, train activity. All of these, I'm going to let you know about them.
Mhm.
Everything I see, I'm going to tell you about. So basically, we're looking for a change from our quiet baseline to any kind of activity here. This is a little bit more about the somatosensory
Perfect. That's what I
potentials.
was looking for.
So
Describe them a little to us.
up here in the top left is where we place our leads. You can see here
These are the
this,
sensory leads.
correct. Our sensory leads are going to run along here, which is that sensory cortex we talked about. Our motor leads are going to be placed just in front over here, over the motor cortex.
Mhm.
We use the 1020 system, which is standard in EEG for monitoring brain activity. This is just a little bit on how we measure it
Mhm.
by sight.
Yeah.
And then this is a kind of a crude look about what a patient looks like with
Can you call them,
neuromonitoring.
like what they know? Obviously, here in the other skull, F is for frontal, C is for central, P is
Yes.
for parietal, O is for occipital,
Correct. The T would be for temporal.
temporal, and then in the arm and the legs. What call us what those muscle groups are or those areas are?
These
or
ones right
nerves
here?
are. That is the ulnar nerve, I'm understanding.
Ulnar or median. I would say this
Okay.
looks a little bit more median,
Okay.
but that's for monitoring the sensory pathways of the arms. The head isn't placed here. Looks like they're doing some kind of facial nerve monitoring in this one. And down here is what the potentials actually are going to look like
Got it.
and how we can measure them.
What are those muscle groups? You want to quickly, do you have another?
Yeah, this is gonna be during a cervical procedure most
Okay.
likely. This isn't how a person's
Mhm.
positioned during a cervical procedure, but this would be the deltoid, tricep, and bicep muscles that we're
Okay.
monitoring. The same principle applies though for when you're monitoring a lumbar case. And this is a visualization of where we get our potentials from. So
Excellent.
for this is the arm stimulating up to the head. And you can see we're recording a response from the brachial plexus, which is where all the nerves from the arm come together into the spinal cord and the brainstem.
Very complex anatomy.
Yes, and that's why we want to keep an eye on it.
Yeah.
And so then we have a brainstem response. So we're looking for the biggest spots where there's the most electricity being conducted
Got it.
to monitor. And then up here's our cortical responses.
In the leg, I see that vastus lateralis. Can you tell us what those muscle groups are for people who are interested?
So this is our vas lat. This is one of the muscles that we measure in the quad. We also will monitor like up a little bit higher the iliopsoas, which is a pretty deep muscle.
The groin, right?
Yes, it's a pretty deep muscle, so it's hard to get super reliable responses from. But then
that's especially important when we do surgery in the higher lumbar spine.
Correct. L1 is that nerve root. Anytime we see L1 on the procedure, we're going to throw the iliopsoas on there. Here's some of the muscles of the quad or of the calf. This is more medial. This is more anterior
and gastrocnemius.
Yes, and the gastroc would be like right here.
Yeah.
These blue ones here are our stimulators.
That's peroneal nerve.
That's going to be the posterior tibial nerve.
Posterior tibial nerve.
It does a better job reaching some of the lower levels.
Got
And then
it.
by reaching the lower levels, we can tell what's going on with the higher
Mhm.
levels too. And this is just a representation of those lumbar ones. You see, sometimes you can record from the pop fossa,
Yeah.
the back of the knee.
Which nerve would that be? That is the peroneal nerve, or?
I believe so, yes. We don't
Okay.
do the pop fossa too terribly often, so
Okay.
I'm honestly not as
Okay.
super familiar with it.
So next.
This is what a motor potential looks like.
Oh, this is fascinating
Yeah,
for me.
so I mean, this can take you back to some cellular neuroscience
Yeah.
where you're seeing the synapses and
It's
the
amazing how much you
depolarization.
can say from just looking at that, how your nerves are doing.
Yes. So this is just a basic visualization of what a motor potential looks like.
So is that your?
I knew we were going to talk a lot, so I didn't
Yeah.
put too much on there.
That was a
Good.
really good present. That was
Thank you.
exactly what he was looking
Yeah,
for. the
good.
advice.
Yeah.
Well, I have two quick questions for the neuromonitors watching.
Wait, stop sharing.
So one of them is going to be during a spine surgery, what is the thing I mean, obviously it's going to vary procedure to procedure,
Mhm.
but if you had to pick one thing about a procedure from neuromonitoring, what's the most important aspect?
The most important aspect is, as you mentioned it already, is the EMG and stimulation, because we put a lot of screw. We want to make sure they are in the right place. And even in my sacroiliac joint, as a matter of fact, most of my colleagues, they do their sacroiliac joint without neuromonitoring.
Mm-hmm.
Whereas, look at that. This is the sacroiliac joint. There are lots of nerves around it, especially the L5 nerve root comes here. The S1 nerve root go through that. S2 goes here, and actually L4 as well passes very close to that.
Yes.
So like even for that, I use neuromonitoring because I want to know if the screw has connection to them or not.
Correct.
For all my screw placement, obviously stimulation of the screw is the most important part. The sensory evoke potential is important for your entire body. Not as important as actual stimulation and free run EMG, and there is a delay in the sensory. It takes usually about, if you cause a pressure on the nerve or damage, it takes few minutes actually until
Yes.
you see the effect in your skull and so on. Now, most of people don't know that when we are born, obviously spinal cord goes all the way down,
Mhm.
but when we grow, our bone grows faster than our spinal cord, the nerve. In an adult, spinal cord stop at what level?
L1, T12, L1, L2.
About L1 is where the spinal cord in average stops, meaning anywhere below that you have just the peripheral nerves. We call that cauda equina because it looks like a tail of a horse. Above that, we have actual spinal cord, and whenever we have a spinal cord, especially those motor neurons make switch.
Mhm.
So, especially if you work in the front of the spinal cord, for people who know, our spinal cord inside of what is it, like a round thing? Inside of that, if you cut it like axially, it looks like a butterfly.
Yes.
The butterfly is where the nerves are. The white around it is where the pathways are. In the front, or mostly in front of a spinal cord, are mostly where the motor pathways are. So especially when we do ACDF, especially when we do on a person who's already damaged and so on, motor evoke potential are extremely important. And but if you do the actually spinal cord tumor, all this neuromonitoring, especially motor evoke potential, is a must. For spine procedure, based on how bad your starting situation is, how extensive your surgery is. Like if you do a corpectomy, you better have a full neuromonitoring.
Absolutely.
But if you do a regular ACDF, vast majority of the people don't do motor. Most of them, they do these days, the sensory and and EMG. But even in 2024, there are lots of surgeons that they don't do any neuromonitoring whatsoever.
Yeah, we're working on it.
Yeah.
And I got one more quick question.
Yes.
I know we got like 2 minutes
No,
left.
we have.
So
You have a call.
as your provider in the room, as your neuromonitoring professional in the room, this is for me, for my teams, for all the monitors out there. What is the most important thing that person in the room can do for you outside of motors or EMG? Like
Communication.
Okay.
Communication. See, now you notice that we have established in our protocol a series of communication. You communicate with the anesthesiologist that the patient cannot be sleeping
Mhm.
or cannot have been paralyzed during the surgery. if you are going to do neuromonitoring for our procedure, because we stimulate as we go. So you communicate with them that this part is important, that the patient is not get a medication that is going to put them out of any kind of sensory or motor monitoring for a period of time. Then obviously we have established, that if we start stimulating and we go slowly up, and it's better that go from bottom up than top down. Some neuromonitoring people, they jump up and then find the threshold from above. Those nerves are already ready to shoot, that you get a higher signal than if you go slowly up.
It lowers that threshold.
So, and one of the things for you guys is don't jump to 30. To start low.
We don't.
I know you don't. But don't jump to 30. Start low, go slowly up. But once you get to 10, 15, then you can go 5 units up and so on and so forth. But don't jump to 30, because if I have contact, that patient will be on the off the table. And then obviously it's very important that during the procedure that we communicate with each other clearly. By the way, that's one of the reasons there are those automated neuromonitoring machines that they say, oh, you don't even need a neuromonitoring person, you just put the machine. That's why I don't like them, because they go up and down until they find the threshold and so on. Those automated systems, they do not work with OLIF.
Right.
That is one of the things that I really need you there to go up slowly, communicate with me. And then sometimes, if you notice, I come and look at your signals.
We put it on a TV for you.
Yeah, you initiated
Yeah.
that. Now, sometimes you get a blip. Is that blip real or not?
No, you
Tell us.
taught me exactly what was going on with that. I knew it was shunting, which is where the current spreads to something else, but it's passing through blood vessels that are nearby and creating not necessarily a false positive, but for what we're looking at, it's a false positive.
So what that means that you go to that signal, then you go 1 milliamp up, 1 milliamp up, 1 milliamp up, and then you find out when you start growing, truly growing, because if you have a contact, that means now we get a threshold. Like you tell me I'm good at 17. But then at 16, you get a blip. At 17, that blip grows. Then we go to the last signal that you had, that blip, you saw that blip. But let's say you get that blip at 8 or at 6, but it doesn't grow until 15 or 16. That means that is just the conductivity of the tissue around that, because if it was the correct signal, it should have grown with every milliamp that you add, that should have grown.
Right.
One of the best part of that is that you get a signal at, let's say at 14 for my Jamshidi. I'm pretty sure it is not, but then you go up, it doesn't go up until you're at 25. But when I put the screw in, the signal goes away. You don't get a signal at 14 anymore, because the screw, which is bigger, compact the material and closes off that vein or vessel that was conducted. So do you have any other advice for people who do your job for OLIF procedure?
Was gonna reiterate the communication thing. I saw recent studies that I don't remember which teaching hospital was at, but 30 to 40% of OR failures, complications in the OR come from breakdowns of communication. So that's something I really stress to my team and anybody else neuromonitoring is, even if the communication's hard, even if maybe a surgeon or someone's going to get mad at you, it's so important.
Yeah.
And if you don't know what they said, just ask them again.
And standardize that communication.
Absolutely.
Like, I say I'm at 3 milliamp, use closed loop. I say stimulate at 3 milliamp. You say
Stimulating.
Stimulating, and I say 3 milliamp. And or when you are stimulating and you get a signal, I say I'm stimulating right L5. And you say right L5 good at 25, and I repeat that, and you confirm that. You say confirmed, and so on. So the so-called closed loop communication is actually should be standard, which unfortunately is still not.
We're getting there.
Yeah. Well, it was lots of information, but I'm really happy we had this podcast. Amanda is ready to move on.
Thank you guys for watching. This was Essence of Medicine. We talked about neuromonitoring. I'm Amanda Armagast.
I'm Dr. Abbasi for Essence.
I'm Jesse Baldwin with US Neuro.
Have a good weekend.